So hyposecretion of renin that is not appropriately corrected by volume depletion. So by potent diuretics as furosemide. So these all are done to confirm the diagnosis. We will discuss in next slides. So IV suppression, don't be worried about these values. Just think that IV saline is given, simple. IV saline is given, and the suppression should be there of aldosterone. What should happen if there is more volume expansion? What should happen to aldosterone? So suppression if its value is decreased. Oral sodium chloride suppression test, you give oral sodium chloride, suppression should be there. Or you give fludrocortisone, high salt diet and large dose of this over a 4-day hospitalization is given. So it should ideally suppress that. If the cause is aldosterone, if the cause is not renin, then it should give the suppression. Are you getting this point? So primary versus secondary. So we are giving the stimulus, we are giving the same trigger, and we are looking the response. If the cause is renin, response will not occur. If the cause is aldosterone, response should occur. So this is how you differentiate. ACE inhibitors, okay, such as captopril. So it decreases the angiotensin mediated aldosterone production, secondary, to less than 15 nanogram, but the autonomous aldosterone production from aldosterone producing adenomas, primary is unaffected. So this actually again differentiates primary versus secondary. So if it is secondary, renin is the cause, so it will decrease the value. But if renin is not the cause, adenoma is cause, then it is unaffected. So this is how you differentiate primary versus secondary. ACE inhibitor. Okay, to distinguish between adenoma and idiopathic adrenal hyperplasia. Now other thing, first for primary versus secondary. Now that adenoma versus hyperplasia. Aldosterone is more, but hyperplasia is there or adenoma is there. So you do the adrenal venous sampling. So what will? This is a gold standard. And ratio, you do the aldosterone to cortisol ratio. If ratio 4 or greater, this is adenoma. Whereas 3 or less, it is hyperplasia. So you take a sample from adrenal vein. You take a sample and you look for aldosterone and cortisol and you do a ratio. Okay? Ratio means divide, you divide it. If 4 or greater, it is adenoma, tumor, aldosteronoma. If ratio is 3 or less, this is hyperplasia. Hyperplasia means it's not the tumor, this is hyperplasia of adrenal. And if it is between 3 and 4, then it is a gray zone. Gray zone means in between. In between. Then what will you do? You will do other things. That adrenal hypersecretion and plasma renin suppression usually greater with adrenal adenomas. So this is a key. This is one of the hint that renin suppression and aldosterone hypersecretion is greater in adenomas. 18-hydroxycorticosteroid is more in adenomas. And after sodium depletion, patient with adenoma usually show no change or fall in aldosterone, while in hyperplasia show a rise in aldosterone. So when you deplete a person of sodium, these hyperplasia patients usually show a rise in aldosterone. So again, these screening tests. So till now we have done, maybe it's too much for you or I am going quickly, I will just repeat. First was to differentiate primary and secondary. In the primary, aldosterone is more but renin is less. In the secondary, renin is more and aldosterone more. First of all, we look at the ratio, aldosterone and renin. Okay. Then there are other tests we did to look for to differentiate primary and secondary. Now we are talking about adenoma versus hyperplasia. Aldosterone is more in both, but either it is hyperplasia of the adrenal or this adenoma. So we did the sampling. Okay. We did the sampling and look at the ratio of aldosterone and cortisol. If it's 4 or greater, it's adenoma. It's less, 3 or less, it's hyperplasia. If in between, do other tests. That 18 hydrocorticoid adenoma, the aldosterone hypersecretion and plasma renin suppression greater with adenomas, and the third thing, sodium depletion, hyperplasia will respond, adenoma will not respond. A paradox means opposite. Opposite means it should not occur, fall should not occur, but paradoxically, in the opposite sense, it actually falls the plasma aldosterone. Instead of rising it, it decreases paradoxically sometimes. So this is an indicator of adenoma. So in a normal person, one thing should occur, but if other occurs, we call it paradoxical, opposite, you can say. Now we talked about hypersecretion. Last thing, I think, the insufficiency. Primary adrenal insufficiency is called Addison's disease. Okay, it is a disorder of adrenal glands in which both cortisol and aldosterone hormones are missing. Secondary adrenal insufficiency, it is more common, and inadequate secretion of ACTH, and tertiary is inadequate secretion of CRH. So same, primary, secondary, tertiary. Primary is the problem of adrenal, secondary of the pituitary, and tertiary of the hypothalamus. So same thing, we will do the ACTH level, basal, cortisol level, along with ACTH stimulation test, and looking at the other signs and symptoms. Okay, now this is an important slide. Please, this is important. Just finishing. Inshallah, within a few minutes we will finish. You are tired, I am also tired. Okay, so please be focused. Okay, now ACTH level. First of all, 8 a.m. random cortisol is the screening test. So in the morning we do the cortisol level, and then ACTH stimulation test is the confirmatory test. This is the first thing. How we do it? 8 a.m. cortisol in the morning, cortisol level. If it is more than 15, so insufficiency is ruled out. What is insufficiency? Means adrenal is not producing. So we rule out it's producing. So there's no problem. If it is less than 3, then go for the ACTH. Okay. If it is in between, then 30-minute cortisol during co-syntropin stimulation test. Co-syntropin is ACTH. So ACTH stimulation test you do. So what happens? If ACTH, after giving the ACTH, the levels becomes more. So again, this is not adrenal insufficiency. If this not high, then you will go after measuring ACTH. I will repeat what I am saying. Just forget the past lecture, focus on now this. Adrenal insufficiency. Adrenal gland is producing cortisol or not. Okay, insufficiency is there or not. Cortisol level, just do it in the morning. If it is more than 15, means it's producing. So no problem, rule out. If it is less, directly go to ACTH. If it is in between, do ACTH stimulation test, means give ACTH and look at the response. In a normal person, what should happen to cortisol? It should go high. After giving ACTH, it should go high. So if it is going high, so it's no problem. If it's not going high, then go to ACTH measurement. Okay, there is some problem, but ACTH level should be there. If ACTH level is low or normal, it's secondary problem. ACTH is there, pituitary is releasing ACTH, still cortisol is not there. Okay? Elevated primary adrenal insufficiency. Okay, means adrenal is not producing the cortisol, as a feedback ACTH is more. Are you getting? Till here we have confirmed this problem that cortisol is not being produced. Body is not producing cortisol. Why? What is the reason? It can be the problem of pituitary or hypothalamus or adrenal. We have to differentiate. So we measure ACTH. If ACTH is there, means this is functioning all right. Okay? So primary adrenal insufficiency, adrenal is the problem. If it is no or normal, the secondary or tertiary means the problem somewhere here. Okay, it's not producing ACTH enough to produce the cortisol. So same thing. Good.
Is it normal? And there's no cortisol. Is it a problem within the
No. Usually when adrenal is the problem, it should be high. Even normal is not in the favor. Okay? Okay. There's one other test, multiple day ACTH. Same rationale. You give ACTH multiple days, not one day. Used to distinguish primary for secondary or tertiary. The same thing. You give adrenal for multiple days. So what should happen after ACTH? Cortisol should go high. Okay? If it's not going high, where is the problem? After giving ACTH, adrenal is the problem. So same is the red. If it's going high, so it means there is secondary or tertiary problem. If it's not going high, primary is. So you can differentiate primary from secondary and tertiary. So same things are repeating, the same rationale, same thing are there. Other test is CRH stimulation test. Now this is to differentiate tertiary from secondary. Are you getting? From pituitary and hypothalamus. What is the problem? So you give CRH, releasing hormone. So it stimulates the secretion of ACTH. So normal response, that plasma ACTH concentration peak 30 minutes after CRH injection. So when you give CRH, cortisol should rise. But if there is pituitary deficiency, there will be decreased ACTH and cortisol response. Even after giving the CRH, pituitary is not responding. Problem is in the pituitary. Okay? And if there is hypothalamus, prolonged ACTH response and subnormal cortisol response. What does it mean? When you give CRH and ACTH going high, so it means hypothalamus is the problem. Initially there was no CRH. Now you are giving CRH. So by this test you can differentiate secondary and tertiary. So in the beginning the tests were differentiating primary and secondary or tertiary. Now it's differentiation of secondary and tertiary. Insulin, same. Insulin what should do? It should raise cortisol level. Okay? So cortisol level should high. No response. So it means there's maybe due to pituitary or hypothalamus cause. There's some secondary or tertiary problem. There's one other test, autoantibodies. You can also measure the autoantibodies. Last slides. Autoantibodies can also help that is there an autoantibody in the adrenal. If they are there, so most probably primary cause. The problem in the adrenal. Okay? So these all tests, if I will conclude, after this slide I can conclude, aldosterone deficiency. Adrenals usually have aldosterone deficiency and there is usually this picture, hyperkalemia, hyponatremia, acidosis. This picture is very important. Very important point I am telling. That look at this picture always. This is a very important sign of aldosterone deficiency. The hyperkalemia is there, hyponatremia is there, and acidosis is there. Okay? So this lecture is finished. Just I will conclude this lecture, and both lectures you can say. There were few questions also in the breaks, you can say. That there are lot of tests are there. How will you do in the actual scenario? Actual scenario, when you are in the hospitals, it's a clinical decision. Okay? It's a clinical decision. What does it mean? The patient, the physician, the doctor sees the patient, history examination. Okay, if it is in favor, he will tell the lab, I want this investigation, screening test. Okay, so screening test will be there. Now, both if are in favor, then confirmatory test. So, then overall picture is seen. This is the history examination, this is the screening, this is the confirmatory test. So now what is the diagnosis? So there are a lot of tests, 6, 7 tests. Maybe doctor will say, okay, I need only 2 or 3 tests. Let's see what will happen, or 1 test or 2 tests. But means all options are there. So if one is not conclusive, you can go to the other option. If one is conclusive, history is there, no need to go to multiple tests. So it's a collective effort. It is a spectrum, means you have to look whole scenario. So these multiple options we have. So concept is primary disorder, secondary disorder, tertiary disorder, feedback is there or not, what is the rationale of the test, logic of the test, screening test, confirmatory test. So this was the theme of these 2 lectures, and tomorrow inshallah the last lecture will all